Okay. Okay, let's wait for one moment.
Sure.
People are still joining.
That sounds good.
Okay, I think we can start. I'll just introduce you, Yara.
Mm-hmm.
And just to give information, we have 40 minutes of your presentation, so it will be around 4:40 Central European time. I think for you it is earlier, and then 20 minutes of Q&A. So then
Mm-hmm.
we will open the floor for the participants to ask the questions.
That
So
sounds good.
let me introduce you. So, hello everyone. Thanks for joining today. So, Yara is joining us from University of Michigan. She is a PhD student in the Department of Computer Science and Engineering there, and she's going to give a presentation on the ethical development of speech-centered affective computing for health, which is a very interesting topic for most of us. So her research interests are centered around AI for healthcare, which includes using speech and activity data to track mood and monitor mental health symptoms, and also around human-centered design to ensure these systems benefit the patients who use them. Before beginning her graduate studies, she worked as a software engineer at Microsoft. She graduated from University of Michigan in 2020 with a dual BS in computer science and biopsychology, cognition, and neuroscience. So we are very pleased to welcome Yara for this first webinar presentation of this year. And thank you, Yara. I give you the floor, and we're looking forward to a great presentation from you.
Thank you so much. Hi, everyone. Nice to meet you. I'm Yara from the University of Michigan, and let's get started. So today I'm going to be talking about the ethical development of speech-centered computing, effective computing for healthcare. So I'm going to start with an introduction about why this is important work to do. We're going to ground it in a frame of reference for in my current work, and look into a bit of a case study, address some open questions, and end with a call to action. So let's get started and kind of set the stage about mental health care and why AI can help. So more than 1 in 5 Americans experienced a mental health disorder in 2021. However, only 47% have received treatment, and this statistic holds up worldwide as well. So globally, more than 70% of people with mental illness receive no treatment. So this is quite a big number. It's a very big deal. It results in a lot of healthcare issues down the line. It ends up causing very poor lifestyle choices, and can be very costly and devastating to people and their loved ones who live with untreated mental illness. So mental health is undertreated worldwide, and there are quite a few issues. So some of them are economic. So especially, it's really expensive to get good, high quality mental health care. Some of it is lack of knowledge and lack of education about why getting mental health care is important is often viewed as not as important as physical health, and maybe something that can be worked through. There's also people preferring to self-help, or maybe it's a stigma surrounding seeking mental health care. Some communities will really look down on you or there's a fear that some communities will really look down on you if you seek mental health care or talk about it in any way. People are scared of consequences for their job or for their family or so on. And there's also other issues that are not mentioned here, such as very long wait times, very low availability of providers, low insurance issues where it doesn't cover mental health care, and so on. So, however, even when you are able to receive care, for it to be effective, clinicians really need frequent appointments and very detailed monitoring. So this can be quite burdensome on the patient because the patient also has to, outside of these detailed appointments, collect very intense information about their symptoms and then report it back to their physician. So, this causes a barrier for patients as well, and AI is actually emerging as a promising solution here. So it would not be a solution to replace clinicians. I want to make that very clear. The clinician interaction with the patient is still very important. However, it can make care more accessible by decreasing the burden of symptom monitoring using digital biomarkers. So basically, our goal is to make it easier for patients to have their symptom data shared with their clinicians so that they have a more complete picture of their health between appointments. So our emphasis is on passive collection, so data that can be collected without patients having to even do anything different with their day. So for example, maybe you're able to get activity data from a smartwatch or heart rate data or other physical symptoms. Or there's also work that shows that you're able to get information on someone's mental health from their social media status. So the language they use or the posts that they share. There's also studies that look into just looking into people's medical records. And what my lab focuses on is looking at people's speech. So speech is great because people talk all the time, and it's very easy to record and passively collect. But we also have to keep in mind that AI can be quite harmful to patients and to people around them. So there are issues that we hear about all the time, including data collection and digital surveillance, incorrect and biased models and decisions, and privacy and security issues. So AI can be very beneficial, can be very harmful, and it's constantly changing, right? So this changing legal and technological landscape leads to many open ethical questions about how we can develop AI while protecting patients and their privacy. And that will be the focus of my talk. But first, let's kind of ground our frame of reference in current work so that we're able to have a discussion about ethics while kind of all having a common ground to refer back to. So my lab works on the Priori project, which focuses on people with bipolar disorder. So how our passive data collection works is that every 5 minutes for 30 seconds, our participants have a device that turns on and collects their speech. So it records their 30-second segment, it sends it to our server, and we take that data and model it in order to have we're working on a long-term goal of being able to measure their bipolar disorder through their speech, as well as eventually maybe even looking into understanding intervention. So this is not really the focus of our lab, but I just want to include these potential applications as examples. So maybe this type of pipeline can be applied to incorporated into medical records so that the physician is able to get symptoms before and between appointments. Or maybe it can be incorporated into their health plan, or maybe even it can just be there is kind of like a alert. So if we're able to monitor a change in symptoms, then maybe we can alert the proper people to intervene if the symptoms become concerning. So like I said, it's not really our focus, but maybe potential applications can be helpful for us to have our conversation today. So maybe let's go back to a little bit more about what I work on specifically. So my work focuses on using patient data to detect depression severity. So specifically, what that looks like is extracting audio and text features and using a Hamilton Depression Rating Score by a physician to train the model to predict depression severity given text or audio or multimodal input. However, this is quite a common pipeline, and having this common engineering pipeline to refer back to will be very helpful as we talk about potential risks. So let's go back to the big picture here. Maybe some things to think about, right? One thing is we are collecting speech data from real people, and some consequences of the types of people we collect from is that it might not be a representative sample. So the models that we train might only work on a subset of people. So there's this great article called Female White 27, which shows that actually a lot of emotion data sets are actually mostly representative of younger American females. So these are also visual data sets. So some of them also don't have representation for people who have glasses or beards, which can interfere with the models. And when they trained models on all these combined emotion data sets, they found that the best model performance was heavily skewed by age. So it worked best on people under age 34. Models also performed better on women and people without glasses. And again, having this important representation can, on a model that will be developed for healthcare reasons, can be very catastrophic if it's not implemented properly. And referring back to the model, a lot of times if the model is incorrect, we get raised a lot of questions. So for example, if the model is wrong and the physician takes the model's recommendation, who is responsible, right? Is it the developer? Is it the operator? Is it the hospital? So it's another open question that we're going to talk about a little bit more. And you might say, well, maybe if the model is explainable to the physician, then it will notice that if the model is wrong and its explanation is wrong, then that will solve it, right? So there was actually a really cool study that was done that showed that even if they showed an incorrect model prediction with an explanation of why that model is incorrect for radiologists, that the radiologists actually were not able to recover from that incorrect recommendation. And even with the explanation, it did not mitigate the negative effects of that prediction. So that issue of AI trust and over-reliance is something that we really need to talk about as well. And we want to make sure that physicians are trained to use these systems without blindly trusting them. And looking into a little bit of the applications, there are the issues that we talked about with incorrect modeling that are being deployed today. So artificial intelligence has been used in insurance companies to deny people care and have them discharged from the hospital early, despite objections from the physicians and the patients themselves. So it was very unsafe for people to leave, and a lot of people experienced harm because of this, and there's actually an ongoing class action lawsuit due to this problem. And there are also issues of digital surveillance. So people really fear their emotions being inferred by AI. And so we have to work to build trust with these patients and in order to make sure that they feel comfortable with such a technology. And finally, these types of interventions also are not very trusted yet. So participants generally have a negative attitude of well-being interventions that happened automatically based off of their activity. So going back to the big picture, these are all things to think about, and I mentioned a couple examples, but I want to make sure to emphasize that while I didn't mention every single part of this pipeline specifically, every single part of this pipeline can be harmful in some way. So, if not implemented correctly, every part can be harmful to a patient. So that's something that we really want to keep in mind as we move forward. So we might say, well, we're just researchers, right? We're just here to develop that technology. We've just got the data, and whoever uses that will be responsible for implementing it correctly and ethically. So I would like to argue that that's not the case. And let's look into a case study about a couple uses of technology and the ways that they have been harmful under current regulations. So I like to look at this example called from a mental health therapy platform called BetterHelp. So BetterHelp actually doesn't use AI. It was a platform that connected people to physicians online in order to be able to get therapy without having to, go through their provider at home. So BetterHelp had people, sign up and provide diagnosis information, health data, their emails, IP addresses, and that data was actually sold to advertisers. So, this is really, really sensitive medical data, and it was sold to Snapchat, it was sold to Meta, it was sold to countless other advertisers, and really broke its privacy promises. So, and that was under current regulations. And while regulations have, are kind of reactionary, they were able to, react and fix it. Researchers moving so quickly that it might not be easy for for regulations to keep up, especially in the AI space. So let's look at some examples. So companies are actually looking to employ affective or emotion computing for non-healthcare purposes, which should really scare all of us. A lot of big tech companies are looking into affective computing to monetize it. So companies engineer our emotions in order to sell us something or monitor us or make us more efficient workers. Emotion AI may be the next big trend for business software, and you're already seeing examples of people developing these types of things in order to, in the name of like workplace efficiency or better bottom line or advertising. Also, AI for health products are actually beginning to be classified as medical devices. So we have an AI health chatbot that gained medical class status recently. Also, the FDA published a list of AI-enabled devices for medicine. So again, these are things that are moving faster than regulations are able to keep up. And finally, something that is even scarier is that with AI research, there aren't very many guardrails. So models are getting released to the general public while being unreliable and unsafe. And then when we find out that there's a problem with them, suddenly they disappear. So online, there are a lot of mental health chatbots that are untested. So we don't really know what they're doing. And another good example in the medical field is the ECG app on your Apple Watch. So it comes with a lot of caveats and disclaimers. When you open it, it says, do not use this watch if you're to check if you're having a heart attack. It also has all these disclaimers like, don't use it if you're under 22, or don't use it to make a clinical decision. So, this is just released out there, but we have to make sure that, it's safe to use. And obviously, in some cases, it's not. And looking also into AI without guardrails, there are apps out there that are just, well, you pay for them. For example, Character AI that's mentioned in this headline, and but they don't have the proper guardrails to reduce self-harm. And then going back to the medical field a little bit more, there's an AI app that only takes medical notes. So, doesn't really interact with people and their emotions. However, people found that it's actually making up things that no one has said and then including them in people's medical records. So these models are, again, unsafe and unreliable. And then when people point out an issue, they disappear. So regulations are clearly not able to keep up with this, constant fast-moving change. So it falls on us as researchers to look into current regulations and also try to make sure that we have a more comprehensive and complete method to develop data or to develop pipelines ethically. So let's look a little bit deeper into current regulations. So a lot of times these regulations, as we mentioned, are not adapted to these advances because they're just going so quickly, like who's able to keep up, especially because regulatory bodies are often slow and take a long time to make a change. So current regulations that we'll look into include the EU AI Act, which is probably the most up to date. There's also GDPR and HIPAA, which is the American Health Privacy Act. So let's refer back to our emotion pipeline. So maybe we can look into a little bit about the data collection, right? So the input speech data, maybe under HIPAA and GDPR, can sometimes actually not be counted as healthcare data. HIPAA has some very specific ways where you can circumvent it. So depending on who collects the data, what purpose it was collected for, and the level of de-identification on that data. And HIPAA and GDPR don't really take into account that de-identified data isn't as safe anymore with the advancement of AI. So AI is actually able to break patient privacy pretty easily, even while following the most intense de-identification. So that's one problem. The models themselves are actually also not classified as healthcare data, even though, especially except for under the EU AI Act. But if HIPAA and GDPR are what's regulating the healthcare area, again, those are not there to protect patients as well. And then finally, the inferences and the whole pipeline itself, again, aren't very comprehensive in protecting data, and there are ways to circumvent it depending on if a physician is working with the data or if an app developer is working with the data. So again, it's just something as researchers that we can't rely on regulations to tell us how to handle these instances to protect patient privacy. So this brings us to a lot of open questions in the field about AI use and specifically affective computing. So one big one is, do we know enough about speech, emotion, and mood to build models used for detection and diagnosis? So, there's still a lot of developing work about depression and mental health. Are we able to actually make those inferences ourselves without having a complete picture? What information do patients and clinicians need? So what do they need out of such a technology? What's actually useful for them to know, and what do we just think that they want to know? How can we ensure transparency in our development processes, in our procedures? It's kind of seems like everyone is kind of doing their own thing. So it's something that needs to be classified as a standard for how to improve transparency. Who's liable for mistakes? So if a model gives an incorrect diagnosis or makes an incorrect recommendation, and then the physician follows it and the patient is harmed, who gets held liable, right? Is it the patient, or is it the physician who made the diagnosis? Is it the model developer? Is it the hospital who required the use of the model? Is it the overall governing body for not having a better regulation? We don't really know yet. So this is an open question that's being constantly debated. What if a model flags need for intervention? What are the procedures that we can take? Who is the patient comfortable with knowing that they need an intervention, so on? And what data can we collect and store without invading patient privacy? And more. So these are constantly changing. And again, the field is constantly changing. So there are questions that arise and get more and more complicated. So something that we can do as developers who maybe don't have regulations to fall back on, there's not really a wide industry standard yet, is we can look into emerging ethical guidelines. So IEEE and some other organizations have started to create guidelines for ethical development. These are not laws by any means, but they're there to clarify norms in the field. So if more people are able to fall back on these ethical guidelines, we have at least kind of a standard to work from that is there to protect patients. So one example I really like is Desmond Ong's ethical framework for the development of effectively aware AI, which establishes our roles as developers or operators. So developers are people who are working on the product, and operators are people who are deploying the product. And I'd like to argue that as researchers, we're often both, right? We're making a pipeline and then we're implementing the pipeline and testing it with people to see if it works for them. So we often play both roles. And so we're responsible for both the pillars of provable beneficence and responsible stewardship. So let's get into a little bit more about what those mean. So provable beneficence is all about proving the AI will benefit the emoters or the people having those emotions. So those include scientific validity, bias minimization, generalizability, AI transparency, and accountability. So let's examine each one of those more carefully. So scientific validity is making sure that we understand emotion and its relationship to health very well before we implement such a pipeline. So it also includes that making sure we're actually extracting the signal. We're also having this thoroughly tested. We're doing clinical trials, we're doing peer review, and so on. So a lot of times in the research field, we are doing peer review, but we just want to make sure that we're going the extra mile to really make sure these technologies work. Bias minimization, which we touched on, means that we have to promise that our results will benefit in the fair treatment of people, so that our models are able to take people with different backgrounds and different medical statuses into account. So this not only means that we have to have diverse samples, so across all age ranges and cultures and socioeconomic statuses and healthcare statuses, but also the people who annotate the data need to also be diverse. So if you have someone a coder who is only from like the United States, maybe you're not going to get some of that cultural nuance that comes with annotations that may come from other people with other backgrounds. So having a concrete step to minimize bias will be really helpful to ensure a robust model. We also want to look into the concept of generalizability, which we talked about a little bit also, which is making sure that the model will perform well on out of data set data. So we want to make sure we're building a robust model that takes into account variability of health and emotion. And finally, we want to look at transparency and accountability. So we want to make sure that we're disclosing our methods, our data cards, our model cards. We're including parameters, demographics of people that we trained on, amounts of people that we trained on. So basically we want to aim for transparency so that we're able to assure quality and reproducibility of these models in order to make sure that we're deploying a trustworthy and beneficial AI that won't harm patients. Also, looking kind of at the operator side, so responsible to stewardship kind of encompasses ownership of responsibility for proper use and care of the data and its models. So we want to make sure that the data and the models are being used for a pre-specified purpose only. We're monitoring the intended and actual effects and outcomes. We're keeping at the forefront privacy, consent, and data ownership, and we're ensuring quality assurance. So examining a pre-specified purpose more closely, this is all about avoiding mission creep. So what mission creep is where the data and models are collected for one reason and then repurposed. So for example, if we're collecting data to only help with symptom tracking, so we want to make sure that we're able to track people's depression symptoms over time. And then we start to use that data or even repurposing that whole model to actually diagnose depression. That's an example of mission creep, and we're violating the consent of the participants whose data was collected in the first place. Another thing we need to look into is monitoring intended or actual outcomes of model deployment. So even if it's at very high cost, constantly surveying patients, physicians, and others in order to make sure that that people are actually getting what they need out of this deployment, and if there is an issue, making sure that we pull any implementation of it immediately to fix the error. And then looking into privacy, consent, and data ownership, we want to make sure that we're using data while maintaining autonomy and privacy. So that involves not only seeking consent from anyone exposed to the system, not just patients, but maybe people around them. But we also want to make sure that they maintain the right to opt out and seek deletion of their data, clarifying where their data will be stored, and not selling any of their data. And quality assurance is kind of parallel with the developer pillar of accountability. So we want to make sure that we're training, troubleshooting, and we're also making sure that people who are interacting with the system are trained to interpret the output and trained to have strict procedures in terms of data control and security, ensuring that any deployment of this model is very secure and not vulnerable in a way that exposes patient data. And yeah, so overall, these should be things that we check before, during, and after our work so that we're able to avoid issues such as surveillance, bias, and security. And make sure that our pipeline is deployed in a way that's ethical and beneficial for patients, so that we don't actually end up exacerbating harm. So the next steps in my current work that that I plan to look into are continuing my model development project and making sure that I'm keeping patient protection at the forefront. So some possible next steps that I'm considering is looking into federated learning, so that making sure that patients' data actually stays with them, so that they're able to feel more confident about such a system being deployed long term. Also looking into making sure that our data is representative so that we're able to train a robust and generalizable model. Also, I have a really cool upcoming project where I'm working on participant-informed design. So I'm actually going to interview study participants, and I'm going to use their feedback to collect requirements to inform model design. So some questions I'm interested in are what data are they okay with collecting? How have they felt while having a passive monitoring system? Have they felt safe? Have they had any negative interactions with people who know that they have this system deployed? What information are they comfortable with physicians having? Any type of intervention that they're okay with, and so on. So that way we're able to ensure that physicians have the data they need, but also that patients' requirements are met for privacy, data collection, and inference needs, so that they're able to benefit from a deployment of such a technology in the long term without having to worry about their safety. So I'd like to end with a bit of a call to action. As researchers, it's really tempting to defer these decisions to a regulatory body, and we'll just focus on the immediate project and call it a day. However, if we take ethics into account early and constantly, we're able to help our speech research be put into the hands of users sooner while minimizing harm, while not exposing patients into more problems, while not violating their privacy, while building better models. So there's this really cool emotion AI checklist that I like to refer back to. It's on emotionai.org, and it has a set of personal, relationship, and societal questions that you can look into. And I'll just go over a quick subset right now. So one question that you can ask is, does this technology treat humans as more than data points? So we're collecting the speech data about patients. Are we taking their needs into account in terms of their privacy needs, their requirements for data that they have access to, who can have access to their data, and so on? Are we also making sure that we have policies in place if need for intervention is inferred? So what do we do if something concerning comes up? How can we handle issues with the chain of command, or who we talk to, or who's allowed to know if something concerning comes up and there is an intervention needed? What does the patient feel comfortable with in terms of an intervention based off of their data, and so on? Do we consider assumptions that we have about speech and emotion to make sure that we're building the most robust model that is also most medically informed? Does this technology identify scope for harm at the outset and as an ongoing process? And do we recognize that collecting speech emotion data can be very invasive? So if we keep these issues in mind at the beginning, during model development, and while it's deployed, we're able to constantly check in on our ethics, on our privacy, in order to make sure that we're avoiding the issues of digital surveillance, incorrect models, and security, so that we're able to, again, provide a safer, more reliable experience for patients. So these questions overall are really helpful to refer back to. And there's also little steps that you can take during your work that can help you have these conversations with others that you work with. So ask questions to your colleagues, just bring it up. It doesn't have to be super formal, but talk to them about whether they think something is okay or if something is concerning. Voice concerns during development so that you don't have to fix a mistake afterwards, because that will be a lot more expensive and time consuming. Lead discussions in your organization about ethics, and if something makes you very uncomfortable, maybe you can try to think about redirecting your project so that it's not creating an ethical conflict. So thank you so much. This concludes my talk. I'm always very interested in talking about this more. So if you'd like to reach out, I'm at el-tawil@umich.edu. And I'd like to end with a quick note. So this is a constantly changing field. So something that we really need to work together on. So both during this seminar and also afterwards, let's talk about it. Please share your experiences and ask questions so that we're able to build technology for good. Thank you so much for coming, and please let me know if you have any questions.